Welcome blind Tom.
Yeah. Oh, you could have told me. I could have reached over for that one.
That's okay. You enjoy yourself.
All right. Welcome to Fertility Fact or Fiction. Now that all of our electronics are up and running, I am your host, Dr. Rahi Victory, double board certified reproductive endocrinology and infertility specialist, who also still does OB and gynecologic surgery. And to my right is the amazing Tarek Ibrahim from Ibrahim Strategies Group.
Hello, everybody. I feel like I'm, in the show Tool Time, Home Improvement.
Yeah.
I feel like I'm always out on hello, everybody. I have that feeling.
That was a great show.
Yeah.
So we don't have a topic for tonight. I did have an interesting conversation with someone this afternoon about their experience. So I think I'll touch on that because I promised them I would. And just talk about some issues in general. But I think it's been kind of a quiet week. So our PGT program is up and running. So I'm proud to announce that. I'm very excited about that. Continuing work on a couple of new projects, and I can't talk about those too much, but they will also be up and running hopefully very soon. We have numerous research projects going on, so we're excited about that. And I'm off to a wonderful conference in Brussels next weekend to help couples who have special needs and need an egg donor or a surrogate. So very excited about that. So if any of you are interested in any more information and need help with surrogates or egg donors, whether you are straight or same sex, happy to chat with you about that as well and the services that we provide. So couple I spoke to today, very, very nice couple from another clinic. I'll remain mute, I should say, on which clinic, but they were telling me about their experience in her stim, and we were talking about it, and I couldn't make sense out of her stim because it didn't make a whole lot of sense. Now, granted, she didn't have the stim sheet, so I couldn't really understand exactly what had transpired. But nevertheless, the important thing with it all was that she said that she actually had been told by the clinic that she couldn't have a retrieval on the weekend because they don't work on the weekend, which made zero sense to me. How can a fertility clinic just close on weekends? Like, egg maturity is critical, and you have a narrow window of time between being immature and being mature and being post-mature. And that time frame is like really narrow. Like, one day too long, you've got post-mature eggs. One day too early, you've got immature eggs. So when you block off 2 days out of the schedule, you're either getting immature or post-mature. Now, maybe by some huge stroke of luck, you're actually getting some mature eggs, but you're definitely hampering your ultimate success rate. I have absolutely no idea how that makes any sense whatsoever at all. If the clinic is closing, they're not optimizing your outcome. It's impossible. Like, how can that be possible? You've got an 11, 12-day window. We know after that, your egg quality diminishes. And if it's less than 9 days, your egg quality diminishes. So you've got that really tight kind of time frame. And if your eggs don't fall in that window and you were supposed to be ready on day 12, let's say, but day 12 is Saturday, you're either going 1 day early, in which case you're getting fewer eggs, or you're waiting till Monday, by which time they're all post-mature. How does that work? Somebody make sense of that for me, because I don't understand how that can make any possible sense whatsoever at all. And this is not the only clinic. I've actually heard this from many clinics. I'm sure because getting people is difficult, finding good embryologists is difficult. We're going through that right now. We're bringing someone from a completely different country, literally on the polar opposite end of the earth. And we have constantly got battles to find good people. But you can't just throw your hands in the air and say, yeah, we're not going to retrieve you because we don't work on weekends. I don't stop working, period. I was doing a consult for someone at 9 o'clock at night last night. That's what this job takes. That's the kind of commitment you have to it. So huge kind of confusion for me. Somebody please make that make sense for me, because I literally cannot understand why you would go to a clinic that does that, first of all, because that makes no sense, but patients would know that. So I don't blame the patient. But the clinic itself, like, how can they possibly be doing that? That just makes absolutely zero sense. Zero.
That's why I go to clinics that are always open, like Dr. Victory.
Yeah, absolutely. So no great articles or studies or anything like that for this week. But yeah, that's where we're at.
Are we ready for the questions?
I am.
Are you,
Yeah.
are you feeling excited for this? We got a bunch.
Oh, great.
They're queued up, ready to roll.
They're already queued up and ready to roll. I'm ready to go.
All right, so here we go.
Yeah.
Question numero uno.
Yeah.
Good evening, Dr. V and T.
Okay. Garden variety, but that's okay.
Garden variety. That's right. Why do you wait 14 days to do a pregnancy test with a 5-day embryo transfer? I see online a lot of clinics testing at 9 days. Thank you.
Well, at 9 days, you need a very sensitive test and it won't always pick it up. And so we wait the full 14 so that the patients actually get a good sense of, is this really productive or not? The other thing is that it's pretty standardized what your beta should be after the 2-week wait. And that's why it's called the 2-week wait. But it's not as standardized for day 9. So we like to wait because we know what to expect, what to predict from that, and how things are going to go.
Hi, docs. What is the substitute for statins during pregnancy?
I mean, in theory, you could take niacin, which naturally helps bring down your cholesterol. I would diet, but you don't need to be on a statin during pregnancy because your baby is using a lot of that cholesterol to form its own hormones. So you need some cholesterol in your system when you're pregnant. Now, if you have like traumatically high, I would probably be talking to a nutritionist, but there is no substitute for a statin.
My TikTok just closed up on me. I gotta open it up.
Yeah.
Is POC testing pointless for a miscarriage with a 6BB euploid embryo? Have endo and roid. My estrogen dosage was too high at 4 milligrams per day.
Well, I'm not sure 4 milligrams per day would be too high, although it's on the margin of being high, but it's something we sometimes have to do if you can't get the lining to thicken enough. The chance that the euploid would come back aneuploid is about 0.7% maximum. So, I mean, in my opinion, that's probably useless. There's no harm from doing the test, but if you had to pay for it, I'd probably say no. So I don't think that's going to provide you with a whole lot of information. You already know it's euploid. The chance it's wrong is minimal. And if you have bad endo, that's not the likely source of why you failed. Unfortunately, I'm sorry that it didn't work.
Dr. Victor, somebody is asking that they have a question and they would like to ask it of you.
Okay.
No, that's the question so far.
Oh.
Hi, Dr. Victor, I have a question for you.
Fire away.
That's where it started.
Great question. Yeah.
Hi, King T and Dr. V.
Oh, there you go.
Here we go. This is what I was waiting for.
Yeah.
How many days of estrase vaginally is ideal to thicken lining in endo protocol?
The least amount is ideal. So 0 would be ideal, but if you need it, the shortest amount of time, right? So like a week, 10 days, something like that. Hopefully it's already thick enough by then.
How long before an EC should I start taking prenatal and all other vitamins specifically for endo?
1 month.
Back to the previous question regarding the 4 milligrams per day.
Yeah.
Followed with, could this have caused high inflammation and ultimately caused the miscarriage?
I mean, anything's possible, but I doubt it. I don't think 4 milligrams per day, which is higher than ideal, but not high, would be the cause of a miscarriage. It's much more likely that it's endo or adeno or your immune system being overactive or not having an endo protocol on board, that kind of thing.
Dr. Victory, with the recent time change, how much wiggle room for PIO injections?
Oh God, that makes no difference at all. At least with us, we have you on so much progesterone, your time doesn't matter at all. It's like really not going to make a difference because we've got you on the shot and the vaginal. So there's more than enough time to move it around, even hours if you needed to.
What's your Asherman's protocol? Ruptured heterotopic in September and miscarried. Other embryo a week later with, it says FU, D, and C, but
Follow up.
Oh,
Not that kind of F you, dude.
I was wondering, I'm like, that's so rude. We're just throwing that out there now?
That's great. Yeah. No, they're not. No, they're not saying
No,
F you to
with a
you.
follow-up.
Follow up.
Of course. Hysteroscopy 4 weeks later, unsuccessful due to scarring. History of endo and thin lining. Thank you.
Well, Asherman's, you need to first restore the uterus. So that requires an advanced hysteroscopic approach. You can use cautery, but a lot of doctors advocate that you should be doing it with scissors so that there's less trauma from thermal damage. We do both, so it depends on the case for us. And then once you've done that, you need to pre-treat the patient with estrogen, continue them on estrogen. Many of us will put in a balloon to kind of help keep the uterus open at that point. And then beyond that, it's really just a matter of see how thick the lining gets. One of the other patients I spoke to today had a problem with Asherman's and thin lining and had had this really traumatic history. And so we talked about that and what's going to be necessary to correct it. And so that's something that needs to be closely looked at. One of the first things I need to do is get a revised 3D ultrasound to see what does her uterus look like after all that surgery and trauma, because that makes a big difference. And for those patients, we very frequently recommend microbiome assessment because I think the majority of them have a disrupted microbiome and restoring it can make a difference. By the way, that the patient I mentioned at the start of the show with the closed clinic, she wanted me to say hello to you.
Oh, no way.
Yeah. She said, say hello to, I think she said Dr. T.
Dr. T, that's
I don't
nice.
think she said King Dr. T, but she did say Dr. T. Yeah.
King's hard for some people. It's a jump.
Lovely
it's a leap of faith, as they call it.
Very lovely couple. The gentleman was so polite and friendly and talked about how much he loved the show and that he got a lot out of it and that they enjoyed the time watching it and stuff. And he was very, very, very kind and sweet about it. Yeah. Thank you. It meant a lot to me. Yeah.
Well, let's be honest. How many shows are out there that patients can say "F you"? You know what I mean? I think this is a record-breaking thing. So, Dr. V, I have here another shorthand that I can't guess.
Okay.
So, good luck to you.
Okay.
Hi, Dr. V and Dr. T.
Yeah.
So my intellect now is being challenged, and I have failed. Can BV cause failed implantation?
Bacterial vaginosis.
Of course. Vaginosis.
Yeah. Oh, yeah, for sure it can. Yeah. I mean, that's a lot of what we spend our time doing right now, right? Microbiome is everything. So BV can very much interfere with your ability to implant, especially if the bacteria are in the uterus, not just in the vagina. It creates a very adverse environment and a pH can be different. The NK cells are different. Your immune receptivity, endometrial receptivity are different. It messes up everything. So there is no question that even a history of BV can mess things up, let alone an active BV. If you had active BV, I would never transfer.
It seems that there's a lot of people that are excited for you going to Brussels, by the way. There's a lot of Brussels, can't wait, Brussels, like Brussels.
Yeah. Yeah, especially if you're in a same-sex relationship, the conference is really important for those people. So anyone struggling, let us know. We will be more than happy to chat with you.
Kind of feeling let down that I'm not there to.
I'm sorry, buddy.
You know, I think I did pretty good in Toronto.
You did do good.
I was serious. I was serious.
You were playing doctor.
I was really doing it. I was above and beyond the call of duty at that point.
You did a great job. We very much appreciate your efforts in Toronto. Yeah.
Yeah, it was a good time. Hi from London. I've been priming with 10 milligrams of testosterone gel daily for 3 weeks.
Okay.
And my follicle count has dropped from 8 to 2. Could the testosterone be suppressing my ovaries and should I stop?
I've never heard of that before, and that goes counter to the evidence. However, there is some evidence that people with high androgen levels who get more androgen don't have the same egg quality. So you might want to get your testosterone level checked now that you're on it and just see if you're like over absorbing it, especially if you're like someone that's really thin. There may be just too much absorption or too quick, and maybe that is suppressing you to some extent. It is possible.
Going back to TikTok, where the people are right now. Hi, doctor. Do you get worried about gestational sacs being 3 to 4 days behind at 5 weeks, 5 days.
No, ultrasound's just not that accurate.
Oh, I thought there was somehow a little bit more to that answer. Straight up
No.
no, eh?
No, I mean, ultrasound's not that accurate. So when they're off by a couple of days, it doesn't mean anything. In that early a time frame, even an expert ultrasonographer like the lovely ladies we have here will be off by up to 3 to 5 days. So if you're off by a couple of days, it doesn't mean anything.
Dr. V,
Yeah,
tips
I'd love some.
to conceive naturally with endometriosis.
Oh, yeah, sure. Use letrozole for your cycle. That's definitely a good one. Consider doing something along the lines of high dose progesterone, or at least some progesterone if you're not doing it already. Take all the natural supplements: NAC, curcumin, resveratrol, ALA, coenzyme Q10. Those are all really helpful as well. And then on top of all of that, I would probably consider doing a little bit of an immune protocol, like at a minimum steroids, or if you can access intralipids. I mean, not all of this is like quote unquote natural. So I get it. That might not be exactly what you want. If you wanted pure natural, I would just use the supplements. But if you want a little bit of something, but you don't want to use IUI or IVF or anything like that, then I would definitely consider doing that. Were you in the dark? Really?
Big dark.
Big dark?
Somehow this angle is massive dark. So
maybe it's the dark room door behind you. You should close that.
No, that's not even in there. I literally just got the soap dispenser behind me. That's all I got. How safe is it to transfer my one embryo to your clinic for FET?
Well, I can tell you that we've received embryos from pretty much every corner of the globe. The farthest being Australia and New Zealand, and we've never had a problem with an embryo. Could something happen? Sure. I'm not going to guarantee you that your embryo is safe, but has it ever happened to us? No, nothing's ever happened to us.
So, Dr. V, can cervical polyp cause infertility?
Yes.
Is endometrial polyp a cause for infertility?
Definitely. Cervical polyp only because it can set up inflammation and create extra mucus, which could block the sperm. But like that would be really, really rare. But an endometrial polyp definitely reduces your chances. Actually, I just reviewed an article for a journal that I edit for that was on that topic. So I can't talk about it yet because it's not published, but there is no question that endometrial polyps have a huge negative impact on the endometrium and your implantation potential, specifically for people doing ART.
There's a bunch of people on TikTok right now, and there's not enough likes for me to continue answering their questions. I'm just going to skip them all together at this point.
Lots of likes on TikTok because we need those likes in order for TikTok to notice us and keep driving the show forward. So please, as you're watching us chat, just on Instagram too, just keep hitting those likes. That's super helpful. Yeah.
So, Dr. Victory.
Yeah.
Why would someone measure behind by 3 to 8 days in their first ultrasound?
Well, 3 days is irrelevant. 8 might be a little bit long, but it depends on when your first ultrasound was. 3 days is within the error margin, but 8 days would be longer. If you're 8 days behind, we'd be worried that the pregnancy isn't developing properly.
Does a C-section defect cause recurrent miscarriages?
Yes, if your microbiome is disturbed, and they have had recent evidence that the microbiome is disturbed more often in women that have an isthmusile. So yes, that is a possibility.
Dr. Victory, possible endometriosis. What steps do you recommend for IVF, i.e., do you remove endo after egg retrieval, or would you leave but do Lupron and letrozole?
So we always recommend that you do your egg retrievals first, because the stim from the IVF will potentially make your endo worse because you're getting higher levels of estrogen. And then with regards to the chances of leaving it versus taking it, you should always operate. Your chances are going to be better with the endo gone than they are with the endo there. Now, is that sufficient, or should you also engage in an endo protocol? We advocate that people should have an endo protocol if they have endo, because you never get it all. It's impossible. But everybody's different, right? So it depends on what the patient wants, how aggressive they want us to be, their tolerance for risks of surgery. Listen, some endo surgeries are brutal. I talked to a patient today. I put the camera in. It was what we call peek and shriek. Everything was stuck to everything. There was no chance I could do it. I needed a general surgeon. Those guys aren't coming unless they have to. So, and then they want like pre-consented, for bowel resection and colostomy and all this stuff. So, like I told her, and she said, you know what? I'm not sure I want that kind of surgery. So, surgery is not always easy, but if you're willing to undergo it, yes, you should. It's the better choice, and you're going to do better too. And the studies support that as well.
Peek and treat.
We peek and shriek.
Peek and shriek.
You look inside and you're like, "Wow, that's not good. I'm getting out of here."
That's how bad sometimes the endo can be.
Oh God, yeah.
Really
Brutal.
Not worth treating.
So this one particular patient I'm referring to had bowel stuck to her ovary, her bladder, which doesn't even make sense because the bowel's not supposed to go up there, and to her uterus and everything else in sight. I couldn't even see the ovary. It was just so.
Oh, wow.
So all you got to do is tug too hard, the bowel tears, colostomy. Oh yeah, it's like major, right?
Huge.
Yeah. You're cutting, you snip the wrong thing, colostomy. You're lifting it up, the grasper pokes into the bowel, colostomy. Like every single thing you do, colostomy. So it's not like a minor thing. They're waking up with a bag.
No way.
And
Nobody wants that.
3 months later when they restore it, and then you got a scar and you're
really.
Yeah, people don't like that.
Nobody likes that.
No.
Forget that.
Camera 2.
Yeah. Dr. Victory, a question from TikTok. Sure.
Are they giving us the likes we need?
They gave us more likes. Okay. Yes, they did.
Keep the likes coming.
Keep the likes coming, guys. It's a team spirit here.
I need a good rant question.
I agree. 27.
Yeah.
Here we go.
Yeah.
This is it. This is your rant, Dr. V.
Okay.
27.
Yeah.
Stage 4 endometriosis.
Whoa. Okay.
With bilateral OEs.
Ovarian endometriomas.
A lot of shorthand today, let me tell you. It's a little bit more than I'm used to here.
Right.
Should I have surgery to have them removed or not?
Well, it depends on what your goal is, right? So understand that when you remove them, your AMH will go down, but your AFC stays the same. So your follicle number stays the same, but your AMH goes down. So it depends on how strong your ovaries are. And it depends on what your goal is next. Are you already doing IVF? Have you done IVF? Are you planning to do IVF? Are you thinking more natural? Or are you thinking IUI? So if you're doing natural or IUI, you definitely want to get rid of the endometriomas first, because you're going to do way better with that. If you're thinking IVF, depending on how big they are, where they are, it's often better to actually first start by removing the endometriomas. By doing the egg retrieval and then removing the endometriomas, if you can get access to the eggs. If the endometriomas are too big or they're positioned such that you can't get at the eggs, then you have to remove them, because otherwise you don't have egg access.
I have a big question here for you, Dr. V.
Okay.
Multiple continuations.
Oh boy. All right.
So prepare yourself.
All right.
It starts off very respectful,
Okay.
I must say.
All right.
So another great way to ask a question.
I'm all ears.
Hi, Dr.
I might
Victory.
make notes.
Yeah. Hi, Dr. Victory and King T.
Okay.
So already
Lovely.
all the formalities
You're
are properly
good.
put in
Yeah.
place. Absolutely. Yeah. My ego is satisfied. I've heard that dexamethasone is sometimes used during the stimulation and egg retrieval phase of IVF, not just for transfer.
True.
In what situations would you use it? For example, is it mainly for patients with endometriosis or other inflammatory issues? And when in the cycle would you typically start and stop it? What dose? Is there much evidence for the use of dexamethasone during egg retrieval phase?
There is actually. We're considering using it. It's mainly being studied in DOR patients. So I am considering adding DEX to our protocol. I think there's now enough evidence to support it, so we'll probably integrate that. So yes, I am considering using DEX. And when should it be started? I have to go back and look at the studies, but it's usually started, I think, around the same time as you start your stim. And so, yeah, it does look like it may be beneficial in DOR patients. I don't think it's beneficial on everybody, but DOR patients definitely benefit.
Hey doctors, is there anything to do for uneven follicle growth? I'm always getting a dominant even with birth control suppression. My RE suggested E2 priming or microdose Lupron.
Yeah, either of those would be reasonable in that circumstance. You could try testosterone human growth hormone priming. That's what we typically do. Or just go to your luteal phase. Let the one big one ovulate and then start from your luteal phase. They may line up better that way. We do that all the time.
Hi, Dr. V and Master T.
Oh,
When doing a standalone luteal stim, when should HGH and testosterone priming start? Right from cycle, day
yeah.
one, or later?
No.
Last time for a follicular stim, I started mid cycle. So I'm curious how it changes.
We would start you at the start of your stim cycle. So if you're doing a luteal phase, we start your priming in the start of your stim cycle. So, start of your natural cycle. So when you get your period, that's when we would start it.
Gentlemen,
Oh, that's nice.
somehow I like it. Gentlemen, for someone who's 40
Yeah.
with endometriosis
Yeah.
and having trouble getting blasts,
Yeah.
how many euploid embryos would you recommend banking before moving on to a suppression and transfer?
Depends on how many babies you want. But if you want one, I'd say 3 or 4, because that's going to give you between a 95 to 97% chance of success. If you wanted to have 2 kids, I'd say minimum 6. So it depends on how many babies you want. Yeah. I mean, it all depends on a lot of different factors.
It reminds me of the study you just tore apart today.
Yeah. So we had a study today. We're coming out with a video, and I guess I can talk about it here because not everybody will see it from here. But so this study is a British study that looked at 1.2 million women. And in this study, they actually said that women over the age of 40 had less than a 5% chance of ever having a baby using their own eggs, and a 30% or greater chance if they use donor egg. So this study is freaking mental. Okay. 1.2 million people in the UK, which is like a huge number of people. And they studied from 1991 to 2018. Okay. So first question, what happened the last 7 years of human existence and massive progress in IVF? They just dumped that. Why? I don't understand. Number 2, they're looking at hugely different time frames. Okay, this is an enormous time period or time span, coming pretty close to 30 years, and a lot has changed in 30 years. The success rates have gone from, they say it themselves, from 15% to 30%, but now we're actually getting 50, 60, 70, 80%. So you can't compare what happened in 1991 to what's happening today. You go further than that and you look into it in more detail, and you got to say, if they're only getting 5% success, that's below the standards in anywhere in North America, Canada, the US. I don't know about Mexico, but Canadian national averages in that age group are higher, 9%, 8%, 10%. And American ones are roughly the same too, about 11 or 12, I believe, in the last SART data set. So all of this stuff is saying their data is basically wrong, or at least not reflective of what's happening now or what should be. The other part, they're getting 30% with egg donors. I would shut my doors if I was getting 30% with egg donors. This just doesn't apply to North American women or North American IVF success rates, because none of us would be in business if our egg donor programs got a 30% success rate. Maniacal, like absolutely does not fit. So I actually hate this study because it's making a big news splash, and they're telling women in the UK, by the way, I'm coming out there soon, ladies, that you should just stop and abandon trying if you're over 40 because you have such a low chance, and you should just go on and go for donor. Well, no, you shouldn't, because you have a very decent chance, especially now that we have all the adjunct treatments. We got PGT, which massively increases your success at the age of 40 if you know your embryo is normal. We have all sorts of microbiome tests. We have immune tests. We have specific endo treatment protocols, adeno treatment protocols. We've got surgeries we can do. There's so much that we can add into your cycle to improve your success rates that we are way beyond 5%. So if they're trying to claim that it's 5% across the board based on data that's already 7 years old, but can be as old as, like 34 years now, that just makes absolutely no sense. I'll give you an even better example. There's someone on one of my vitamin K posts right now who keeps screaming about the fact that there's evidence that vitamin K caused jaundice, and they're trying to propose a study from 1959. Like, can it at least be this century, for the love of God? This is the dumbest thing I've ever heard of. And they're insisting that they're right based on a study that has been disproven in innumerable modern studies, but that they still are harping on, saying, well, you're not accepting it. That's evidence. It's not evidence when it's being disproven. That's a lack of evidence. If something came around and then somebody else showed that it was wrong or disproven, it's no longer evidence. It's like garbage. It's used for, starting fires in your fireplace. That's not useful. The paper that it's printed on is useless. It's no longer evidence. So we can't say that that's evidence anymore because it's being disproven, and they're still harping on it, saying, no, 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 this is evidence. So this is the same exact thing. Something that happened that long ago is meaningless and cannot be applied to modern day IVF. Can't be applied to vitamin K either, but it definitely can't be applied to IVF. IVF is like a daily changing game, and you're either with it and on top of it and you're good and you're at the top of your field, or you're not. And I won't describe what that really reflects.
I won't describe it either.
Yeah, not good though.
Not good.
Not good.
Dr. Victory,
Yeah.
superficial endo, not on ovaries. Proceed with IVF or opt for cervical excision first? How to avoid aggravating endo with IVF? A lot of endo questions today. You notice
Did it
that?
say cervical excision?
Surgical excision.
Oh, surgical. I thought you said cervical. Yeah, I mean, the research shows that you're going to do better if you excise. So, I mean, I would advocate for that. It's not for everybody. Like I said earlier, you have to be aware of the risks. You have to have an excellent surgeon, but there's no question that, you should learn it. We have a great new resident working with us who actually wants to do infertility in her future. And so we were doing surgery together, and I was teaching her how to do surgical excision of endo the other day. And we had like a great big patch about that big that we had to remove from a lady's side wall. We did that safely. It was on the ureter, it was on the blood vessels, got it all, took it out. She had other patches that we had to remove, also in dangerous location. We did it perfectly. It went brilliantly well, not a drop of blood. So, there's easy ways to do this and do a good job, but you got to have the training. You got to have the surgeon. You got to have the confidence to do it. You can't be nervous around the big bad uglies like the major blood vessels and the ureter. As long as you know what you're doing and how to do it, it can be done safely and well, and you get excellent outcomes from that.
Dr. VNT, I'm in my first trimester and can suddenly eat foods I've reacted to in the past.
Okay.
Not a true allergy, but a food sensitivity. Is this common?
Oh, yeah. I mean, pregnancy wreaks havoc with your tolerance of foods, right? Your immune system changes, your immune tolerance of foods changes, your sense of smell changes. Some things set you off, some things don't. Food aversions occur, food likes occur. So all of that stuff changes when you're pregnant. So yeah, I mean, anything food-wise can be very common.
Good evening, Mr. T and Dr. V.
Okay.
Missed a test this cycle due to OR wait times. Is this the norm? I'm not sure what to expect in this fertility journey and keep my expectations realistic.
Missed the test this month? I don't know what that means. Missed what test?
A test this cycle.
Missed a test this cycle because of OR wait times?
That's what I read.
No clue what that means. What test requires the OR? I don't know.
You don't know either?
No.
See, Dr. V and Dr. T don't know.
Can you elaborate on that question? Because I don't know what that means.
I was told your clinic doesn't do FET on the weekends.
We try not to do FET on the weekends, but we're open on the weekends and we're doing egg collections on the weekends. And if someone needs an FET, we do. Once we get our next embryologist, we will be doing FETs on the weekends.
With endosurgery, do you do excision or ablation fulguration?
Yeah. Um, so superficial endo has no difference whether you excise or you actually do an ablation. If it's deep infiltrating endo or it's an endometrioma, you have to excise. So most of the time we excise, we ablate when it's like really small and very superficial. But the majority of the time, the stuff I'm dealing with is tougher. So we're doing excision.
You ready for this one? This is a good intro.
Okay.
You might smile. Hi, Kings.
Oh, I'm now graduated to being a co-king. I like that.
Welcome. Welcome.
I wasn't a co-king before. Yeah.
The view's good from up here. I
Yeah.
was told
Yeah.
20% chance rate for IVF due to 0.27 nanograms per mil of AMF, but baseline gave AFC 6. Will my chances go up? I was told I need to be very aggressive with IVF if using my own eggs.
How old is she? Did it
Not
say? It didn't say,
It
right?
didn't. No, it
Hard
didn't.
to know without knowing your age. I mean, if your antral follicle count is 6, depending on how old you are, you may need multiple cycles. Keep in mind, very aggressive can mean different things. So if they want to give you a high dose, 100% don't do that. There is very clear evidence that it is damaging. I actually just reviewed an exam as part of my American board exams that showed that or not an exam. I reviewed a paper as part of my American board exams that demonstrated that there's a higher rate of embryonic mosaicism when you use high doses of meds. High doses of meds is a disaster. It should not be done. But multiple IVF cycles, yeah, you may need that if you're, let's say, 40 and your AMH is 2 and you're only having an antral follicle count of 6. You need to go into it knowing you're going to need to do it a bunch of times. So these are things you need to factor in and you need to consider. TikTok.
There's a lot.
Excellent. Fire.
Fire away. All right, TikTokers, are you ready? Scrolling back up to where I left off, or should I just
Whatever you want.
All right, guys, don't be mad if I miss some. There's a lot. Dr. Victory,
Yeah.
this question is for you, apparently.
Okay.
I'm 39.
Yeah.
Is it too late to freeze eggs?
I spoke to a 39-year-old today who wanted to freeze her eggs. It's not too late, but you need a lot. Like the estimate at that age is you probably need somewhere around 30 to 40 eggs to achieve 1 to 2 babies. So you need a lot of eggs at that stage of your life. It's not too late. If you have a strong AMH, it's possible. But if you have a lower AMH, then I would want to have a long chat with you about what your financial, medical, psychological, emotional expectations are so that you're prepared for whatever it's going to take. Yeah, it's not too late, but it's tough.
I think that's the most important thing people have to understand, right? Is what is the financial obligation and what is the emotional obligation of these things sometimes.
I agree completely. That's exactly what it is, right? Some people are, aware and they go into it fully prepared. And then other people, they're like, what do you mean I need to do it again? And they just didn't know and they weren't told. And the clinics just tell them, oh, just try again. Not cool.
Not cool.
Not
That's
cool.
what I'm saying. People need to know.
Yeah.
For recurrent miscarriages, Dr. Victory, is endometriosis something you look for right off the bat since it takes a while to have a specialist do a laparoscopy, or you would think this is after a failed implantation?
Yeah, I mean, endo is probably less of an issue for recurrent miscarriage. There is an association with higher rates of miscarriage with endo, but it's less of an issue for recurrent miscarriage. It's more of an issue for recurrent implantation failures. So I'm not saying I don't think of it. In fact, I had a patient that fit that today, and we talked to her about the fact she might have endo. but she was getting pregnant quickly. She was just miscarrying, but her symptoms still suggested endo. So that's why I said this is something we should consider. Having said that, I think that overall, um, it's much more likely that the endo is related to implantation failures than it is to miscarriages. So I'd be much more focused on whether or not there was a miscarriage than I would be, an implantation failure than I would be a miscarriage.
Dr. Victory, 6.1 weeks, but measuring 5 to 5.5 weeks. Yolk sac, fetal pole, 2 millimeters, but no heartbeat. Is this a concern?
How many weeks is she?
5.5.
No, you probably won't see the heartbeat for at least a day or two. So I would just get rescanned.
What do you think of an AMH of 10 picomoles for someone who is 35?
Slightly below average. We like to see about 15. Still manageable and not something to be panicked about by any means. AMH is just a number, guys. AMH has never been shown to predict your outcome. It doesn't predict whether you're going to be successful. It doesn't predict whether you're going to fail. It doesn't predict anything other than how many eggs you're going to make, which will guide you in terms of how many cycles to anticipate. And you should get that information. I see people all the time that don't have an AMH and they were told they don't need it. Well, of course you need it. You need to be prepared for how many cycles you're going to need so that you're not getting that endless, repertoire of just try again, just try again, just try again. I like to inform and educate my patients. You're going to need 3 rounds. You're going to need 2 rounds. You're going to need 1 round. This isn't going to work for you. You need an egg donor. Like, this will help me guide them. So AMH does not predict success. It just predicts how much your time, effort, maybe money you're going to need to pour into this in order to make it work. It's not even associated with the number of euploid embryos you make. So don't focus on the number in terms of, it's going to get me there. People with low AMH can have success, and people with sky high AMH sometimes don't. So that's not the issue. I had a recent patient who made 30 eggs. All 30 eggs looked great when we were doing the stim. Retrieved them. Very, very few of them are mature. And now I have to do genetic testing for her to see if she has a mutation, because I had a long chat with her and said, I'm sure there is something genetically wrong here. And I spoke to someone that I really trust in the fertility world. And she said, yeah, you're right. There probably is. She should get this testing done. And so now we're testing the patient for that. She's talking to another good friend of mine in the States who looks at these types of cases and will analyze their genetics. So we need that kind of advanced testing to figure this sort of stuff out.
Dr. Victory, here's a question for you. They didn't mention you by name, but I would assume it's for you since it seems quite medical related.
Okay. I got you. Yeah.
Why might a clinic use orgolutron on cycle day 1 and 3 before starting stims? Unfortunately, one of those clinics that isn't open on the weekends. Could it be to affect the retrieval dates?
I have no idea. I guess so. I mean, I'm not sure physiologically how that would help you, but that doesn't make any sense to me. It would, in theory, retard the response to the drugs on those 2 days. So it would blunt the response on those 2 days. So, I mean, that might be why. Makes sense.
What you say makes sense to me as well. Seems reasonable.
I'm glad you agree.
Yeah. After all, Dr. T has to.
Dr. T. King Dr. T.
Yeah, I got to confirm these things. If I don't confirm them, if I don't rubber stamp these things,
it doesn't count.
Might not count. Might not count. Is dual stim, Dr. Victory, helpful for those with low AMH?
Dual stim? I think you mean duo stim. Yeah, for sure. That's been proven time and again. Lots of studies. We've shown it. And in our hands, our patients tend to do better often in their luteal phase than they do in their follicular. So it's something we offer a lot of patients.
I'm really happy with this one here.
Okay.
Hi, guys. Smiley face.
Excellent. Yeah.
I've heard that people struggling to conceive coincidentally get pregnant after a saline ultrasound. Yep. Is this a thing or a mere coincidence?
No, it's true. It's very true in hysterosalpingograms. You get about a 2.7-fold increase in your pregnancy rate. We see it with our saline infusion sonihistograms. I'd say somewhere close to about 10% of our patients get pregnant just from getting the SIS with us. And we're known for probably being the most gentle with doing an SIS of anybody. So yeah, we see it all the time.
Dr. V, when you do, let me read this again.
Okay.
Dr. Victory,
Yeah.
how and when do you decide whether to do booster lit during pregnancy?
Oh, well, Dr. Veneriatis from Fertility provided me with a couple of studies that show that there is a benefit to doing lit even into the pregnancy. Now, I leave it up to the patients. It is kind of pricey, but we leave it up to the patients to decide. So we have a package for doing a bunch of rounds of lit, and we offer that to them. And if they want it, great. Am I pushy about it? No, but the evidence does support it. So I think it's a reasonable consideration.
In an earlier question tonight, Dr. Victory,
Yeah.
about estrase use for patients with endo,
Yeah.
you said you stopped estrase once the lining is thick enough.
No, I don't necessarily stop it. We might decrease the dose. Sometimes we'll stop it if they're getting too thick. Yeah.
Yeah, she basically said, "Can you clarify?" So
yeah. So if it's too thick, we stop. If it's like getting kind of thicker than we want, we'll drop back down the dose. So we adjust constantly. We don't like have one size fits all and you just stick with this. I'm monitoring every single patient myself and looking at every single stim sheet. And then I make individual decisions with the team and we decide what to do.
You know, I feel sometimes that your endo protocol, people want to believe it's like a cookie recipe. You know what I mean? Like, I have endo, take this cookie recipe, is good. But what people forget, and I think it's very important to make this mention, is that sometimes different flours, different chocolate chips, and things change. Some ovens not the same as other ovens.
Right.
You know, there's only one Dr. V, guys.
We definitely changed it up based on each individual patient, including dosages, progesterone levels, the supplements, your immune protocol. Sometimes everything's different.
Now we have a bunch of unique intros for us coming up.
Well, we only got 10 minutes.
Yeah, but they are fighting for their question to be answered, and therefore the
All
creativity is right over here.
All right.
King T and the Majesty Dr. V.
We really got to put a stop.
No, we will never stop.
I am no one's majesty. I want to say that right now. I am the court jester in my own home.
Everybody is a court jester in their own home.
Yeah.
But on this show,
yeah,
a little bit of love.
Yeah. Can I just throw a shout out to my daughter's best friend, Natasha, who actually surprised my daughter today in Scotland, who's lovely nice. and very often watches the show. So Nat, we love you. And thank you for going to see the J.
It was such a pleasure. This is the continuation of the Majesty, Dr. V and King T. Just to remind you where we are on this question.
Yeah.
It was such a pleasure to meet you last week. My ER is on Thursday. My ESG is 25K, 27 follicles. How is this looking for success on Thursday?
Spectacular. I mean, that's like, Halo level, awesome response. That's going to be amazing. You're going to do great.
Like I said, they're fighting for their questions here. People understand the system.
The system. They've learned that they're gaming the system. I don't need any accolades. I'd like my wife to tell me she loves me from time to time. That's all I need.
That's very optimistic.
And my daughter.
Daughter, okay. I can give you that.
Yeah.
Wife saying I love you and you're the best and you're a king.
No. I don't need best and king. Just I love you. I'm never gonna get on the king.
King will never happen at home. You're lucky to be slave or servant.
Thank God she's asleep in Scotland right now. Yeah.
Hi, Legendary T.
Oh.
Absolutely.
I love it. Yeah.
And the famous Dr. V.
Oh, only in my own mind. Yeah.
I can't decide if we should just do ICSI or Zymote ICSI. Husband's sperm count is low, 8 to 12 million, 25% DNA frag, 50% progressive motile sperm.
The problem with doing Zymote is that you're going to end up with very few sperm. And with that high a DNA frag and that low a count and motility, I'd probably recommend you do the two samples 3 hours apart. It reduces DNA frag by 80%. You'll just get better quality sperm. They won't need the Zymet. They'll just find what they need. That would probably be what we would recommend here. Yeah. But talk to your lab, please.
Hello, Your Majesty T and Dr. V. It's just a day.
It's just a good
It's
day.
just a day.
Yeah.
You got 8 minutes left of this greatness. just so you know.
Yeah. I'm good with just hey Rahi. Like I don't need
You don't need,
Yeah,
but I ain't reading those ones. Those
like
ones are
it.
not going to make it through. Anyone that's referring to you just as first name basis, no
they're
way.
out.
That's not even accepted. That's out of here. So, Dr. V,
Fair enough. Yeah.
CIS shows
Yeah.
possible mild adenomyosis.
Okay.
Should this be tested further? How do you test for an adeno? Or should you just do FET protocol for adeno without further testing?
So if it's mild adeno, you're not going to operate on it. And so I would just do an adeno protocol. Can you test it further? Not really. The only other test is MRI. So, I mean, I would just go straight to an adeno protocol.
35 weeks pregnant.
Oh, cool.
Baby is.
I love preggers questions. We should do a pregnancy one. Like just, we're only taking pregnancy questions. That would be fun. Get all the pregnant women on board.
You can definitely handle that space.
We could. Yeah. Yeah.
This would be a new arena for me. I would really be testing my lived experience.
We should do it. We should do that. Fertility Factor Fiction.
Pregnancy edition.
Pregnancy edition.
Yeah, it's good.
Yeah.
35 weeks pregnant, Dr. Victory.
Yeah.
Baby is frank breech.
Okay.
Anterior placenta.
Oh.
Do you think baby is likely to flip?
Unlikely, but go on your hands and knees like you're crawling and stay like that for 15, 20 minutes per time. That's going to give your baby the best chance to flip. I wouldn't try a version, which is when we put our hands on the tummy and spin the baby around externally, because you've got an anterior placenta. There's too high a risk of A, failure, and B, abruption. So yeah, hands and knees and see if it'll flip. That's about the best chance you're going to get.
Hi. See,
Hi.
This is your kind of question now.
Yeah,
Hi.
I like that.
That's
just
it.
Simple, humble.
I don't know about humble, but hi.
Yeah.
I've had 4 failed IUIs.
Oh, sorry.
All
Rough.
4 had the dominant follicle on the right side.
Okay.
Is there any way to boost my odds of producing a viable follicle on the left side if the blockage is suspected on the right?
Yeah, sure. Do shots. Easy. Like do some Menopur or Recavel, Puregon, go on the left, whatever one you want, but like do some shots. It'll boost the number of eggs you produce on both ovaries.
Hi, doctors.
I know you love that. That's your favorite. I mean, the Majesty was getting up.
That's
there.
good. That's good.
Legendary was good too.
What I like about High Doctors, and I don't mind His Majesty, Lordship, Kingship, T. These are all very well accepted.
They're all good.
But what I like about Hello Doctors is, now this might sound a little bit ridiculous, but we're on equal playing fields here. Hello Doctors.
Hey,
it does not specify.
We both have the same kind of car. We're already on equal playing fields.
Well, you know, that's a unique metric you got there. Does a hatching blastocyst have a higher success rate compared to a non-hatching?
Yeah.
And are all of your transfers hatching?
So not all of our transfers are hatching for sure, because it depends on the stage of the embryo. Does hatching have a better chance than anything else? Yes, of course. That's been well documented.
High Legendary T and famous Dr. V. Oh, we did this one.
Yeah.
But it was just so good. So I read it again.
You wanted to read
I couldn't.
Yeah. What about TikTok? You've missed them forever.
Well, it's not that I'm missing forever. It's just that, I have to.
They've been giving you those likes, man. You need to.
Well, we'll give them. Oh, you know what? They slowed down on the likes. That's why I've slowed down on the readings.
Yeah.
I informed my fertility center that I suffer from endometriosis.
Yeah.
And they did no testing. Red flag, she asks.
Oh God, that's a huge red flag. Run. Any clinic that doesn't pay attention to endometritis does not know what they're doing. It's clear as day that it negatively impacts your success. So you should have it treated. So you should have it tested appropriately and treated. Tarek and I just made endometritis videos using M&Ms.
You will love it.
You'll love it. So yeah, definitely stay tuned for those, but run. Definitely run. Turn around, take your money, take your embryos, run
As fast as you can.
as fast as you can.
Because if they're not even willing to test it, there's no way on earth they're going to be treating it.
No,
Right?
that's crazy. I mean, that's absolutely nuts to say that endometritis isn't important. Endometritis is hugely important. The data shows that endometritis is important. We know that patients that have endometritis have reduced implantation, higher risks of miscarriage, probably long-term risks of preterm labor as well, premature rupture memories, all those complications of pregnancy. And to deny that it's important is just to deny loads of data. You can't just make up facts. I have to say this to all the vitamin K people every day, but you can't just make up facts and say, whether you're a doctor or someone out in the lay field, you can't just say, oh, it doesn't matter. Of course it matters. People know it matters. The science supports that it matters. So you can't say it doesn't matter. This is critical stuff.
I'd like to take this moment right now to say that even though I am not by definition a doctor, by definition,
Yeah.
not by spirits,
Yeah.
by definition,
Yeah.
I know endometriosis makes
Matters.
a huge difference.
Yeah.
So if a doctor doesn't, you know what I'm saying?
Worrisome. Very worrisome. Run.
Dr. Victory, where are you located, please?
Currently at the end of the counter here in Windsor, Windsor, Ontario, St. Catharines, Ontario, Sarnia, Ontario, soon Woodstock, Ontario, and London, England after the new year.
Dr. Victory is an 8-millimeter polyp, a big deal for a 42-year-old.
Yes.
It's a big deal for anybody, right?
It's a big deal for anybody.
That's right. If I have a 2 surgery, can I have a third one natural?
What?
If I have 2 surgeries, can I have the third one natural? I guess, I don't know.
No idea what that means.
Okay. How long should you try and get pregnant at 36 before you may think you may have infertility?
6 months to a year.
Hi, guys. Can a saline ultrasound actually help women conceive, or is this a mere coincidence?
We did that.
Did we?
Yeah.
Okay. Well, they asked it again. Cheating. What protocol would you recommend for a 40-year-old, 1.5 AMH, DOR, AFC of 14 to 20?
What? Oh, maybe nanograms per mil. That's not DOR. If your AFC is 14 to 20, you've got strong ovaries. Any protocol will work. But if you're DOR, we have a DOR protocol. That question doesn't make sense. Sorry.
My sister had a miscarriage 4 months ago.
Okay.
Sorry, I read it all wrong. My sister had a miscarriage at 4 months pregnant.
Oh, I'm so sorry.
And has been trying and nothing for 6 months. Why?
Oh, I need to talk to your sister. Could be bacterial infection, which would have led to a 4-month miscarriage, which then could prevent pregnancies. So I would need to talk to your sister. 9 o'clock.
Do we ask questions here?
Yeah. Thank you all for watching. Appreciate you being here for Fertility Fact or Fiction. Next week we will be back, probably with a exciting new show, and I'll have a topic for you. And we'll have a podcast or a live with this amazing young lady that makes these incredibly nutritious oatmeal dishes, who's one of my favorite ever medical students. So I'm going to get her on the show, and she's going to show us how to make oatmeal dishes, and Tarek and I are going to make complete idiots out of ourselves. So join us next week on Fertility Fact or Fiction. We will see you then. Many thanks for watching, and stay